are a UK-based society whose aim is to make a fair and just world in which equity in health is a reality for all. Go back. So we were founded in October of 2018, and we're actually part of an international network of 125 different countries with over 1.5 million students. And our organization at Cambridge has 6 different subcommittees focusing on different topics, one of which is the Global Health Lecture Series, which you are all taking part of today. So here are our different subcommittees that we have in our Cambridge branch. We have, as I said earlier, the Global Health Lecture Series, but also subcommittees such as Poverty and Health, the WHO Simulation, the Subcommittee on Sexual and Reproductive Health, Race and Health, and Access to Medicine, which have many other, all of which run events periodically throughout the year. So you can look at our social media and our website to, if you're interested in seeing the events that these other committees are putting on. This event will be recorded, and we will eventually be posting it to our YouTube channel. And you can also, as I was saying earlier, if you're interested in any future events, be sure to follow our social media. We're on Facebook, Instagram, and Twitter for updates about that. And the Global Health Lecture Series will continue this time next week. We're having Julia Robinson with us, who is a clinical instructor at the School of Social Work and Global Health at the University of Washington in the United States. And that will be at the same time as today. So today we are very lucky to have with us Dr. Felicity Aulio and Dr. Shiri Noy. And today our lecture series, or the title of our lecture is called Concepts of Care. The talk today will focus on defining what exactly constitutes care and how those who are interested in global health, from medical professionals to parents, can broaden their understanding. Our talk will feature our 2 academics whose research has looked extensively into how care has developed differently throughout the world and how we can broaden our understanding of care beyond the strictly medical. Dr. Felicity Aulio is a medical anthropologist trained in public health education and ethnographic filmmaking, with a primary area specialization in Thailand and a research focus on care, moral practice, and social change. In her book, Rituals of Care, Karmic Politics in Aging Thailand, she explores habituated processes of providing for others, along with the transformative potential of such acts. She is currently a 5-college assistant professor of anthropology in Massachusetts. Dr. Shiri Noy is an assistant professor in the Department of Anthropology and Sociology at Denison University in Ohio. Her research and teaching interests are primarily in political sociology, centered on development, science, and religion, and mixed methods. Her book, Banking on Health, The World Bank and Health Sector Reform, was published in 2017. And we are so lucky to have both of them here with us today. So I think we're going to let them do a brief introduction first before we get the discussion underway. I should also mention that we're going to leave some time for a brief question and answer session at the end of the discussion. Please feel free to put your questions in the chat or send them directly to me. And we'll have some time at the end to read those out. So thank you, everybody. Does either of you have anything that you'd like to introduce before we get started?
Yeah, I thought I had a few things to say just to, in anticipation of your questions.
Sure.
And so thank you so much. It's such a pleasure to be with you. Thank you so much for inviting me. And I wanted to spend a couple of minutes just talking about some of the things I discuss in my book, which I think will open up some of the questions you were posing for this discussion. So Rituals of Care is based on the work I did primarily in northern Thailand. And I start at the bedsides of elderly family members in what is understood as a rapidly aging society. And then I move on from there to examine care as practiced in more general ways, like care for one's group or care for the nation. And so I want to just say that I start with a very broad definition of care, namely simply providing for others. And in thinking about care as providing for others, you have to ask what counts for whom in context. And so, I'm an anthropologist, and this opens up a lot of ethnographic questions. And it really invites us to take a look at what people do and what they pay attention to. So I'll give you a couple of quick examples just to ground us. So starting at the bedside, what people are doing: powdering, massaging, bathing, cleaning, feeding. Not what they say they do or what's important, but what people are doing. Or move into other spaces, like an everyday greeting. In the Thai context, rather than a handshake, you'll bring your hands together in a Y. And the height of your hands will depend on the relative status between the people greeting one another. Or if you're entering a public space, like say we were together in the conference room, you would scan the room to make sure that, for instance, your head didn't go above the head of someone of a higher status. So these are socially constructed hierarchies, right? They're based on markers of prestige that are really just values circulating. And you're trained to see those things. So you can literally move your body in a space in relation to others. And these, you form into habits, and that you train to observe in these ways, and then what stands out in context becomes what's naturalized through repetition. And I can go through a lot of examples of how you can see that happening. So that brings me to call my work critical phenomenology, which is the study of the social training of awareness, and then the lived experience that stems from that kind of habituated attention to the world. So I just want to say that care, then, I want to applaud you for this kind of focus, because I think it's a very powerful object of study, and also a really powerful orienting focus for practitioners of all kind. I want you to appreciate how you can look to how people care for one another. And you can tell a lot about the people and the organizations with which you work also, including some of the paradoxes that are uncomfortable and often contradictory. So let me say just two more things about this, and then let me wrap up. Is that in this book, I really argued that social, political, religious structures are embodied in habituated practices of providing for others, in care. And this is not always a rosy picture. You can see how values and other social constructs like hierarchy are trained in perception through repetition and social dictates and so forth. So that what you're forced to pay attention to by your social world is naturalized in perception. It's felt as real, as the way things are. So much so that people can feel cared for and feel they are providing care to others through practices that simultaneously ensnare, oppress, and otherwise do violence, despite, say, ethical commitments for equality, for instance. And so, even though care is not always, I would say, like a good necessarily, it can make us so sensitive. At its best, this invitation to be focused on care should decrease our righteousness, and increase our humility. Now I'm being prescriptive. You can take this or leave it. But I think that if we can see the way we're providing for others in our habits, then we can be sensitive to the way we think care should be, and we can be sensitive to the way that care is felt by others, and we can really develop a kind of solidarity, understanding that we're all ensnared in these kind of contradictions. So those are the things I wanted to put on the table. I'm so curious what Shiri, you'll see.
Great, thank you so much. Great. Now we'll hear from Shiri.
Yeah, so I think this is, so first I have to give my normal caveats with an added one today. I'm on my cell phone because I'm having laptop problems, which is why I look like a passport photo. My cat periodically decides that he needs to contribute to the discussion, so just bear with me. But I think this is such a wonderful pairing, because I really start at the opposite end. So I really, start at the region of Latin America, right, and at the World Bank, which is a really global, right, international organization, trying to figure out how the World Bank defines healthcare in particular. I don't really focus, or in this work, I don't focus on kind of everyday lived experience, which I think is so important, right? But my my kind of focus is on the policies. And then I think that there's so much good work about, you know, what that actually means on the ground level, right? Which unfortunately my work doesn't quite tackle. And I think absolutely ethnographic and qualitative methods are much, much better suited to do. But for me, it was really a question of how the World Bank defines healthcare, how that definition has changed over time. So for those of you that are less familiar, in 1980, the World Bank commits to official lending in health. So it does some health stuff before, but so it's really kind of a nice starting point to see where it goes. It's also organized by regional directorates, so it makes some sense to focus on a region, in my case, Latin America. And then I did field work, interviewing kind of key informants, so pretty elite and high level policymakers, to ask them kind of how they experienced health sector reform and kind of what the World Bank was doing. So, and that was in Argentina, Costa Rica, and Peru, which were chosen for theoretical variation on a number of dimensions. But what was really interesting is both how countries defined healthcare, and then how they resisted, negotiated, influenced kind of the way that the World Bank did healthcare, right? So I think by necessity, my research, and I think this is something that I have been thinking a lot about as I've moved recently to kind of looking at infant mortality as an outcome, is, you know, what does the indicator mean, right? So, you know, involved in these questions beyond the interpersonal is, you know, how do we measure care, right? How do we know it's being done correctly without like without talking to everyone? And I think that that's a really, really big challenge for nations and international organizations. And I think it is very critical, because I think exactly as Felicity said, we might be measuring the wrong thing, right? And saying, oh, you know, we're making big strides, ignoring hierarchies and other kinds of dimensions. So, yeah.
Thank you both so much. So you've each already touched a bit on what care looks like in your respective fields. So I guess another good question would be to ask is, how can we as students or as people who are interested in global health fields broaden our own understanding of care to better understand the role that it plays in global health systems?
Well, you know, let me just say that, yes, like, let it allow you to invite curiosity, invite observation and assessment. And I would say that both of embodied practices of yourself and others, as well as that which is embodied at this policy level that Shiri is bringing to your attention. So it's not just what people say, or what they say their indicators are measuring. Sometimes there's a way in which you can be very curious about what is actually provided for by the practices and the rhetoric. And indeed, you know, from my perspective, can be very liberatory. So let me say, one, you can ask yourself, like, for instance, how are you living? You know, what are the ways in which you're busy in your accreditation or bureaucratic audit kind of standards? What parts of those bits of your life that actually make everyday life go are in service of your ethical goals, and which ones seem to be at odds? And if you're assessing your habits in this way, or the habits of your organization, or the habits of the policies that you're investigating, then you can help one another to make sometimes very subtle changes in these habits. Because really everything can stem from here. What are our structures other than habituated actions? And so indeed, this is especially important for everyone who's entering the field at this moment, to be attuned to care.
Thank you. Shiri, do you have anything you'd like to add?
Not, I think, a lot. I think that really gets to the heart of it. I think, you know, the thing that I would say in terms of thinking about care is really the importance of a multi-dimensional or kind of multi-viewpoint, because what I find is that a lot of people disagree when they think they're talking about the same thing. And exactly as Felicity said, we tend to think of care as coming from good intention, right? But we all know, I think, in our studies that intention doesn't always translate to outcomes. And I think that, comparative work is always really good because we're so situated in our own, kind of structures, right, and rituals, etc. So I think for me, that, and then also, is care a means? Is care an ends? Right? That's something I think a lot about in relationship to kind of healthcare, again, at the really kind of broad policy level, right? What are we trying to achieve, and kind of how do we get there?
Great, thank you so much. All right, so I think this is something that is applicable to both of your work, as you're interested in pretty different places in the world. But to what extent does globalization affect health policies around the world? And what are some key factors that shape health policy depending on country or region? And I guess care policy more broadly.
I assume that Felicity was going to go first because we had established a
Right, exactly. I was trying to mix that up, right?
Feel free.
Yeah, no, it's fine. I just, Zoom is like already extra awkward. So yeah, that in a lot of ways is the question that's kind of guided my work, right? And I argue that, the World Bank is kind of a uniquely important institution to look at. It's both normatively really important, and in Latin America, it's the single largest external funder of health. I think it was also globally, at least according to Ruger's work in the Lancet in 2005, that shifted with changing kind of landscape of health financing. And I think that, there's a lot of kind of discussion of neoliberalism and how globalization pushes neoliberalism. And I think that that's certainly accurate, but I think, the big kind of work that I do in my book is trying to figure out exactly how do we measure neoliberalism in health, right? Beyond just kind of basic privatization, right? What kinds of policies look neoliberal when we think particularly at health policies? And I think that the other thing that I've been thinking a lot, and I certainly am not, I haven't like done any research on this, and I'm not, I'm as expert as everybody else who's trying to learn about COVID-19, but I've been following kind of the Peruvian case, which is one of my case studies, and I think we often think about globalization, national context, economies as influencing like health outcomes and health policies, but what we find is that something like COVID-19, but also other kinds of epidemics, even kind of other challenges like non-communicable diseases and epidemiological transitions actually circle back around, right? So it's very kind of, I don't want to say simplistic, but I think, it leaves a lot kind of off the table to think about globalization as kind of a one-way influence, right? It's a constant kind of dialogue. So that's mostly my take.
Yeah, I think that's great. And it's certainly true that WHO policies, for instance, can be very effective when someone makes a proclamation from one of these international organizations. It can be very effective insofar as health administrators and policymakers in the country can turn to that, and in order to galvanize support in their country. But, like Thailand, Joe Harris is a sociologist who works on healthcare policy, and he's done this great new work on how influential Thailand has been as the propagator of models that then get propagated through the WHO. So as Nori was saying, Shiri was saying, pardon me, the directionality is not always like following the kind of simplistic global hierarchies. So there can be global south to global north dissemination. I also want to say that some of our large apparatus is not the only thing that's linking us globally. So I always think back to the Bandung Conference and the non-aligned movement, those who were saying, we don't want to follow the capitalist way or the communist way, we're going to find a third world way. And these kinds of alliances that are also putting forward globalization influences that we need to be sensitive to. So I guess that's what I would add. I think it's globalization is very powerful, and it comes in many different forms.
Great, thank you. So sort of on a related note, what are some of the political and or economic gains or drawbacks for countries that facilitate humanitarian intervention, aid, and care? And also, how are the countries that receive that aid affected?
You know, I have to say, like, that really depends. I mean, it depends so much that I almost wonder if you could say more about where your question is coming from. Just
Sure. Yeah, I guess if you want to speak specifically about your respective fields of study. So yeah, Thailand and Latin America in particular.
hmm, Sherry, do you have something that you want to add, like, while I gather my thoughts on this?
Yeah, absolutely. So I think that this is, and I I'm part of a joint anthropology sociology department, and so it's just really fascinating, kind of both the epistemological, but also just kind of methodological and other kind of viewpoints that we come. So this is you know, a question that sociologists kind of get asked all the time, really broad strokes. My work is mixed methods, so I'm looking at like 19 countries over 20 years, and that's like very common. And certainly anthropologists would never do that. So we have a lot of really fun discussions in my department. But I think that there's a lot, and again, you know, I'm going to speak primarily to my case, and let me also put in a plug for Joe Harris's work. That is fantastic. He's a dear friend and colleague of mine, and his new project in particular is very interesting. But the kind of political and economic gains are several fold, right? If you start from a kind of you know, world systems perspective, right, understanding the idea of dependency and already kind of colonial legacies and exploitation, et cetera, then some would kind of argue that it's kind of necessary, right? It's built into the system, right? This kind of foreign, I don't know if we want to call it intervention, right? Or other kinds of things. The debt crisis, I think David Graeber's book on debt that actually starts with the Latin American case is a really good place to look for how that system gets routed. But I think that, again, you know, as Felicity was saying, there's a lot of complexity. I think some of my favorite insights, and they're not really necessarily new to my case. So Kurt Wayland and James Vreeland, who are both political scientists, wrote about this. But in Latin America, there are a lot of leaders that would make kind of austerity cuts in healthcare and otherwise, and say like, oh, the World Bank, the IMF made us do it. But in fact, they were, you know, the evidence that they found suggests, and this came up in some of my interviews, they actually were using that as a cover to kind of promote their own policies that they wanted to do, right? So there's kind of a lot that happens behind the scenes, right? Kind of in front of the scenes, et cetera. And I think that in a lot of ways, the IMF is really not my specialty. I know some about it, but certainly the World Bank also operates in this way. There's thresholds, right? So if you have a certain GDP per capita, you're eligible for certain interest rates, right? So there's actually weird kind of incentives and disincentives for doing all kinds of things. The last thing that I'll kind of say is that in this case, you know, what strikes me and what I think a lot about is kind of longevity and sustainability. And that's been a real critique of kind of not just World Bank, but NGO projects, right? It's great, they come in, but then you find abandoned clinics, right? All the money runs out, and really we don't have kind of a lot of continuity, right? Which I think speaks to the importance, which I always think about, right, of solidarity, right, of kind of, and that's what single payer systems get us, right? Everybody feels like they're on the same boat, you know? So yeah.
Interesting. You know, I have so many like thoughts on, not sure where to land this. Let me just think about this, the political or economic gains for a country that facilitate humanitarian intervention and aid. The gains be, so take the Thai case where they entered into structural adjustment for a brief period after the economic crisis in the late 90s. And then with the utter failure of that type of intervention, they brought to the fore a very controversial and very powerful and popular populist leader who was really on a mandate to stave off that kind of austerity project of structural adjustment. And so there were all of these very strange bedfellows that came out of this very particular, what they call taxonomics, which is drawing back into old formulations of neoliberal ideas in which very interesting welfare state policies were serving to propagate a kind of investment in entrepreneurialism. And so you have the start of a single payer, essentially a single payer healthcare system, which was coming on top of a very robust volunteer program and lots of small grant funding for community health type of work, as well as extrajudicial killings and a kind of like, there's pros and cons to all of these things. And that leads me to drill down a little bit into the kinds of alliances that then sprang from that, including, say, if we take the volunteer organizations, there was a lot of influence of the Taiwanese Buddhist Tzu Chi network of volunteers that started to have a lot of influence or relation in the Thai sphere. Now, there's many gains and alliances there. There's a changing of orientation, some could argue, and I have argued in my own work on what was being propagated through that kind of volunteering, a kind of heart and mind and alliance versus the kind of showing up and doing orientation that has been the norm. So again, all of this to say, this question is a beautiful one because it asks us to get very specific. And so you can look at the level of the global institutions and policies and get broad understanding, which is very important. And then you drill down and ask how that lands in a particular country, in a particular history, in relation to these global systems and its own spheres of influence. Not, again, always assuming that you know the flow or directionality of influence from like a Euro-American center. Not always a center.
That brings us nicely to another question that we were hoping to have you discuss is, how do you think that ritual and religion play into people's conception of care, and how does that affect those who both give and receive care, or those who receive,
Well, I'm just talking, so I'll just keep rolling and this way, right? So I define ritual very specifically, very broadly, in fact, namely through repetitive acts that achieve their performance achieve their effects, that is, through correct performance, and not necessarily from any particular internal orientation to the task. And you could argue that I come to this precisely because of the religious context in Thailand, what is emphasized in rites as well as bedsides, from temples to bedsides. And this brings to mind a lot of, this relates to the kind of post-Reformation Protestant baggage that I think many scholars walk around with, in a kind of heart and mind and accord type of orientation, where the Reformation, many people have said, was a trial of ritual, and ritual lost. Like, doing things by rote came to be like less than that which was heartfelt. But that is one kind of claim and one kind of orientation. And certainly in Thailand, there's different strands of Buddhism and other traditional influences, values of providing for others, best practices for dealing with karmic burdens, all operating in healthcare as well as elder care. And again, this arises when you take into account what counts in context, who is seen as obligated, and how people feel empowered or agentive, or perhaps not. And the part of the question that I really want to draw our attention to is the part about receiving care, because I think that's super interesting and often, surprisingly, not at the fore of what we look at. I think people are conditioned, I guess, to respect some people more, to weight attention from some or care from some more than others. And this is not necessarily categorically. It can be, you know, personally too, in relationships, and you can all imagine that in your own lives too. So I think I would love to see more work trying to figure out how to pay attention to how care is received. And there's more to say about that, but let me pass it over. What do you think, Shiri?
Yeah, this is, I mean, I study religion, but primarily in the US. So this is really a little far out for me, certainly the kind of religion piece. I think a lot about rituals in a, perhaps unsurprisingly, in a more macro way in this context. So I think about global rituals, right, and systems, and kind of which countries are willing and able to contest, right, the existing rituals. So, you know, I'm thinking of a couple of particular kind of things that I encountered in my field work and in my document analysis and such. So, in Costa Rica, there's some evidence that the World Bank was really supportive of Costa Rica's effort to kind of reach more rural communities. And they started these EBAIs, which are Equipos Básicos de Atención Integral de Salud. It's been a while since I've said that, but like basic teams, right, for integral health care. And Costa Rica is basically a universal system, and these were, sometimes they're clinics, but a lot of times they're like on the road, right? And there was a big debate about whether a doctor needed to be there or whether a nurse was sufficient. And as you can imagine, the World Bank is like, it's fine, a nurse is fine. And, you know, the Costa Rican authorities, the Social Security and the Ministry of Health were like, that's not going to fly, right? So exactly kind of Felicity's point in terms of authority, right? So the way in which kind of the ritual of seeking, you know, medical care, and which is only a small part, I'm sure, I'm sure we all know of healthcare, but the part that kind of is focused on in these kinds of negotiations. And the other thing is, you know, kind of religion, but also just culturally based. There's some really interesting things and efforts happening in Peru and in Ecuador with indigenous people. So trying to have a curandero, or like a local kind of medical person, health person, right, alongside our kind of Western understanding of medicine. So I think, you know, partly it's exactly, I think, Felicity's point, that we think a lot about how to push what we think care is, but we've thought maybe historically less about the reception, right? Just assuming that as soon as we opened up a clinic, people would line up, and that's not necessarily been the case.
Yes, yes. You know, you're getting me to think also of a major religious, you could say, influence on the sphere of global health, which has been liberation theology and the efforts of Paul Farmer, Jim Kim, Partners in Health model, which really, you know, really did change the landscape of global health funding, and about through a focus on the preferential treatment of the poor, the poorest. And that came directly from liberation theology, where they were challenging the global structures to say, we can provide, for instance, Boston level quality biomedical care to the poorest in the Northern Hemisphere, namely Haiti, as a case example of bringing forward a change in priorities and orientation. So it's interesting to start to dig down into how religion is playing, values are playing. And I can't help but say one more thing, forgive me. I wanted to bring Lisa Stevenson's work into the conversation, particularly in this idea of reception of care and how what is done for people can be felt as violence. And her work is phenomenal. In particular, she has done remarkable work in a book called Life Beside Itself in tracking the Canadian state's response to the tuberculosis epidemic among Indigenous and Inuit people in the 1950s. And contemporary suicide epidemic among Inuit youth. And this is, again, a settler colonial case. And she, with great sensitivity, shows what she calls anonymous care. That is a kind of value of care that Canadian health workers, for instance, understand their work to be doing. Caring for you, we care for you. And yet the anonymity of the kind of, it could be anyone there. We're there to help you in an anonymous kind of way. Your identity, not really of matter, is felt as murderous. And so that is a powerful example of how we can begin to attune to these
Thank you both so much. I think we have time for one more question before we open things up to question and answer from the, or open up space for question and answer from the audience. But I had one more question, sort of related to what you were discussing earlier, which is how do structures like humanitarian aid, volunteers like you were talking about earlier, or even voluntourism interact with or mesh with or even clash with existing healthcare structures, whether that be a national healthcare system or parental care?
Sherry, you want to start this one off?
Yeah, what Felicity said also made me think of this this kind of excellent point about liberation theology. It's really interesting because my most recent publication, where I, for the first time ever, like you would think I would have gotten there sooner, delve into health outcomes, right? Because so far I've really only looked at policies. And I look, using quantitative data from the region for kind of more recent years, regressions with selection, et cetera, and then document analysis of kind of World Bank project documents. And what's really funny is that, well, I don't know if funny is the right word, but the World Bank too is very, very concerned about poverty, right? And ostensibly the IMF, right, they're pro-poor, they're pro-growth. But again, this gets me back to kind of what I was saying about means and ends, right? The focus on the poor I kind of outline in that paper is the logic is a very human capital logic, right? Like we should invest in people because they're future labor, and children in particular, rather than because, they're human beings, right? And that is particularly dangerous because, and I think this gets a little bit to your question, Caroline, it starts to fall apart when there's kind of ideological disagreements, right? And in Latin America, again, this is not an area of expertise of mine, but religion plays a lot in kind of reproductive health, right? And thinking about who has access, right? And I interviewed several kind of former health ministers, and this kind of came up as kind of distinguishing different administrations, right? And in Argentina, it's kind of really active at the moment. So I think in terms of what we see in Latin America, I don't know if disruptive or constructive is kind of helpful, but it's a little bit, and the word that my respondents use is segmented and fragmented in a lot of these countries. Peru is probably kind of a little more typical than Argentina, which is unique with kind of labor union roots of organization of their health, and Costa Rica's universal and kind of fairly egalitarian comparatively. And there's just a lot of segmentation, and that creates a lot of kind of confusion. It creates differential access, and as I mentioned, it creates a lack of solidarity, right? Where one system comes under attack or lack of funding or et cetera, some people will say, well, that doesn't affect me, right? Which I think certainly is also something that we see in the US, which again, I know anecdotally because I live in the US, but not kind of as a research scholar. And I just, as kind of another point to the religion and ritual, again, far from my area of expertise, but there's some fantastic sociologists. I think Tara McKay is at Vanderbilt, Rachel Robinson is at American, Nicole Ngati, and they do work in Malawi and other nations. I think they're expanding in Africa, looking at LGBTQ discourses and kind of how LGBTQ plus kind of individuals come up against the different political and health systems. So I think that's another kind of reference if anybody's particularly interested in that.
Yeah, that's so cool. I guess I will add about, I guess I'll return it back to the way care can help us here, possibly. You know, like scholars love to push their own framework. So here I am doing that, you'll forgive me. But the way that I'm thinking about these things is in providing for others. And if you take a look at policies and what they're after, the IMF and the World Bank in various iterations over their history, and it could be, and it has been argued, that they are providing for the economy, certainly, much more than providing for people's well-being, because there is an assumed relationship between growth, economic growth, and the capitalist model and human outcomes. But if you're asking what counts for people in context, that could look very different. And what would it be like if we disentangled that global apparatus from its dedication to modernization theory and economic growth, and change those coordinates through a lens of calibrated care? Well, maybe there would be some other outcomes, other markers. You know, dare to dream.
All right, thank you both so much. That was really interesting. So we have about 15 minutes left for question and answer. So if people would feel free to put any questions they have in the chat, either to me privately or just in the general one. I've already been PM'd a couple of questions, so we can get started with those. So we have our first question asking if you could elaborate a bit about the role of neoliberalism and its influence on perceptions of healthcare, both at the policy and the individual level.
Do you want to start, Felicity?
Yeah, sure. Let me get back in the mode, you know. How do we define neoliberalism? Well, I often look to the IMF's structural adjustment program as the clearest marker of neoliberalism, in a dedication to privatization, that is liberalization, and what's the third one? It'll come. So if you think about what these programs were asking, they were asking for governments to step back from doing anything but allowing for free markets. And that included privatizing what had been state-run enterprises. So neoliberalism at that level can be seen simply in those terms. Now, that comes down all the way into very personal and individualized moments, where that privatization then begins to be felt at the individual level when you become responsible for your own health and for your own X, Y, Z. Because the state is no longer supposed to be providing in those ways, but rather is meant to just allow that free market to take care of everything. You know, that's the guiding principle. And I think Salman Khashoggi's book called Blind Spot is one of the best explications of neoliberalism and its effect on global health explicitly. And he works from his own experience and fieldwork in Russia as a stunning case example of this. So I really recommend that book. As far as, I think there's one other thing I wanted to say, but it's gone, so I'll pass.
Yeah, I think, you know, in the, you know, as Felicity was saying, we all have our preferred frameworks. Sociologists in particular love a 2x2 table. So I look at kind of the different those are the dimensions that help me kind of understand or select kind of my case studies. And I'm not arguing necessarily for representativeness, but I think they're kind of instructive. But which is health autonomy and health capacity at the national level. But what I do in the book is I try to kind of outline this idea of when we say health at the policy level, what are we trying to get, right? And I use the kind of framework of paradigmatic goals, right? Paradigms, and then policy instruments that are used to achieve those paradigms. And so the big paradigms that emerge are equity and efficiency. And really, I think it is hard to overestimate how important those things are, because when you read kind of classic economics textbooks, I think I cite Mankew's textbook in my book, who knows, it's been a few years, you know, they really argue that as the pie gets kind of, as things get more equal, the pie gets smaller, right? Because of this focus on kind of the market and profits, right, and motivations. But then the other thing that I do, because I got stuck exactly kind of where Felicity is talking about, which is, you know, we think of neoliberalism as the privatization of state-led industries, but that's not really super common in health, right? That's really not, at least what the World Bank was kind of doing. A lot of these countries in Latin America didn't have a kind of well-developed centralized system, maybe, you know, the exception of Costa Rica and Cuba. Brazil's developed, right, something interesting. So I argue that, you know, the kind of six, you know, instruments that kind of emerged for my research are decentralization and deconcentration, which again, some argue is very equitable, right? Because every region has its own needs, right, et cetera. But what we find is that it may actually serve to promote inequality, right, between regions. There's some Colombian case studies, which are really nice. The other one that's probably, you know, very neoliberally seen is performance-based financing, right? So people get paid based on kind of what they do. But again, you know, in these countries, I think it's important to remember that, at least in the Latin American context, the focus on the market didn't come from nowhere, right? It came from really predatory states. So it didn't kind of arise in a vacuum of like wonderful states, you know, necessarily, or wonderful leaders, I should say, doing wonderful things. The third I talk about is separation of functions across institutions, right, bureaucratization. The fourth that I talk about is targeting, that can, again, be very neoliberal. You focus on one group, but can also serve to focus on the poor or the, you know, conventionally underserved, right, and this kind of stuff. Private sector involvement, again, there's this big private public partnership push in international organizations. And then sixth, the primary healthcare model, which is really the Alma-Ata model, right? It's seen very much as a equity, non-neoliberal approach, but in fact, sometimes is co-opted by saying, oh, we don't need to give them hospitals, like clinics are enough, right? A nurse is enough. So again, just the way in which these things get framed and used neoliberally or not. So hope that helped.
Yeah, can we stay on this a little bit longer, because this is so important, and I think people like are hungry to have scaffolding for neoliberalism because they're hearing it all over. My university and the neoliberal policies, what does that mean? I know what's happening. And in fact, I think we can hardly even think outside of it because, as I was saying, you know, it's been repeated and repeated, so that in fact we naturalize some of these things. So let us go back to this like Homo economicus as the founding frame of who are people in the neoliberal model. They are rational and efficient. Like this is the mode by which we are allowing individuals to make their own decisions, not being. And one of the wonderful things that Salman Khashoggi does is he draws attention to how this was not a descriptive model. This was an ideal type. It's not meant to actually capture how people work in the world, but it is how policies assume things work in order to bring about certain things. And so in this way, we begin to think that efficiency is the most important factor. How many of you all feel that in your work? Like, I have to get this done. I'm not being very efficient. I'm not, you know, you start to order your own life based on these models, but they're not the only ones. And we just brought up Alma-Ata, which was kind of vision for health in the 1970s that had a long list of that which counted, including pharmaceuticals and drugs and biomedicine, but also water and sanitation and local resources. And I think we would do well to track dispossession at the global level through these systems, because selective primary health care is the classic neoliberal model that replaces alma ata as being pie in the sky. That's great, we'll get there someday, but first let's do the efficient thing, the things that we can really measure. Let's do these couple of things, like oral rehydration and vaccination. Great. And then they slowly shrink what is possible in the visions of health for all. It's that shrinking, I guess, I would love for people to be able to try to get attention to. How is our vision narrowed? And how can we begin to see other possibilities that are existing around us outside of these neoliberal frames that feel like the water? You know that old joke about the two fish? And they're swimming, and they swim by this big old fish, and the big old fish says, "Hey boys, how's the water?" And the two fish swim away, and one looks at the other and is like, "What's water?" I'm like, sometimes I feel like the neoliberalism right now is water we're swimming in. We can hardly see it as something constructed.
Yeah, and I think I just want to jump in real quick. This is kind of, Felicity said it much more elegantly, but this is kind of what I was trying to say in terms of the rituals of systems, right? When you're in the framework of a system, you think the only way to do this is to get a World Bank loan, right? That too is a ritual, right? And as Felicity very kind of elegantly said, we default to it and we don't even know that we're doing it, right? Because it's our water.
Thank you both so much. I think we have time for maybe one more question before we have to sign off. But so this was a question about elder care specifically. So the person who asked the question pointed out that in Asia, the elderly are normally taken care of by family, as opposed to in more Western society, European societies, the elderly often go to care homes. And she was asking about, do you think that religion or any other factors have an influence on the discrepancies in elder care in, I guess, these two different paradigms?
Yeah, what an important question. I do think there's something to be said about, in the Thai context, for instance, a felt obligation to give back to one's parents, for instance, through care. But in a funny, there's a lot of rhetoric right now in Thailand that families are no longer doing that, and they're throwing their elders away to be cared for in homes. But demographic analysis has shown that hasn't really been playing out, even though that rhetoric is drawing a lot of attention. And in the American case, somewhat surprisingly, a lot of care is done at home. A lot of care is based, the burden is on family members, or assisted by low-paying jobs that are very precarious in the home care sector. So I think the economies in places have a lot to do with how and where people are cared for. And I think this is a shifting landscape. There's a lot of migration from poorer places to be providing care for wealthier nations' elderly. I read a really fantastic piece that's not out yet. I don't know who wrote it, but they were talking about care homes in the global South for Europeans and Americans, and the kind of like outrage that Europeans felt at shipping your elder away somewhere, and the binds that families felt, and also the ironies of allowing some mothers and fathers and grandmothers to travel to care in other places versus sending your elders away. Sorry, I'm not being so articulate, but I want to just say that again, it's not always so clear whether the discourse plays out, and these are agonizing decisions for many people, and so I haven't seen such stark contrasts as we might want to put on them. I hope that helps. That's what comes to mind right now.
I have to hop off in just a couple minutes because I'm conducting an interview, but and I don't study elder care, and I certainly don't study it in Asia. So I'm sure this question was for Felicity, and it was answered really well. I just want to note, though, that back to kind of the discourse about neoliberalism, the way that things are framed is it's either individuals or it's the state, right? But in fact, what we see is that it is families, right, that end up taking up the burden, right, when the state or other kinds of institutions do not. And that is also very gendered, right, and has to do with a lot of other kinds of inequities. And, you know, again, not my area of study, but, you know, to Felicity's point, there's also a lot of kind of within country rural to urban migration to kind of care for elderly who are of higher kind of socioeconomic status, I guess, within these countries. So.
Well, thank you both so much. We really appreciate you coming to speak with us. And I know that I personally learned a lot. So yeah, thank you once again. For those who may have had some unfinished questions, this recording will be on our channel, and feel free to reach out to us if you have any further discussion topics, I guess. But yeah, I thank you everybody so much for coming, and to our two speakers, thank you so much once more.
Yeah, thank you.
Yeah,
thank you so much.
And feel free to email. I'm sure I'm speaking also on behalf of Felicity, but feel free to email us if you have any questions. Thank you so much.
Bye.